Hi, I'm Dr. Leon Popovitz. Thank you so much for joining me. Today, I wanted to just give you a case study, a case situation. I saw a patient recently. The majority, if not all my patients, are essentially patients that are looking for surgery. This patient is a high-level athlete, educated young man. He did his research. He suffered a acute traumatic anterior cruciate ligament tear. That's the ACL, which is a central ligament inside the knee. It's really very crucial to stability, particularly rotational stability and anterior instability, forward instability. And he read about the advent of ACL repairs as opposed to the gold standard that's been present for decades and decades and decades, which is the ACL reconstruction using a graft, where we take a portion of your knee, we harvest it as a graft, we prepare it, and we implant it into your knee to replace that ACL ligament. Decades and decades ago, before the development of that operation, it's been tried to repair the ligament back onto the bone, and it did not work. It did not heal. It's a very small ligament, although a very crucial ligament inside the knee. More recently, with the advent of more secure fixation techniques, which are the techniques we use to fix the ligament back onto the bone, ACL repair has had a rejuvenation. It's being done more and more. But you have to be careful about whom you utilize that procedure on. And he read about it, and he came in, and he was determined to have the repair, and he wanted me only to do the repair. Educated young guy, a young man, and he said, "This is what I want done." So I examined him. He was clearly unstable, consistent with ACL instability, where we do physical exams, such as a Lockman test to see the test, anterior draw test. These are all physical exam signs. All was positive on his exam. His x-ray looked fine. There was no bony fractures. Sometimes we see what's called a Sagun fracture on the x-ray that would indicate there's a ACL tear, but he didn't have it. Sometimes there's what's called a tibial spine fracture, a little fragment where the ligament attaches to on the tibia will avulse, come off of the bone, but he didn't have that. So his x-ray was fine. And his MRI showed for the most part, a mid-substance tear of the anterior cruciate ligament of the ACL, which is a tear right in the middle, really a little bit middle or slightly above the middle region of the ACL. Now, the standard indications for an ACL repair, or at least the ideal candidate for an ACL repair versus a reconstruction, would be someone who has an avulsion off of the femoral bone, the top bone, where the tendon comes right off of the bone, not with the bone, but off of the bone. And the tissue is robust and healthy, and there's a good amount of that tissue. Those patients are really the ideal candidate. Those kind of tears are the ideal candidates. But his tear was not that clear cut. It was a little bit more, vague about it. He was adamant about having the repair. He did not want to have a reconstruction. I was already, I think, third opinion maybe. And he really wanted the repair. And the other two surgeons told him fine. The other two surgeons were willing to do it. I was reserved about it. I explained to him, look, I can do it for you, but you won't have the same likelihood of healing and returning to the same function as if we did a full reconstruction. I explained to him that if there was more tissue in that ACL to repair back onto the bone, I would certainly consider it. But to be very honest with you, because of his high level of athletics, even repairing it would be a debate as well, because the jury is not fully out. We have decades and decades of evidence that the reconstruction allows patients to go back to professional athletics at the same high level. But we don't have that kind of data for ACL repairs, particularly in high-level athletes. In fact, we, for the most part, are reserved about doing it on professional, collegiate, high-level athletes. He really, really wanted it, and I had to be very honest with him. I would say might be inclined to consider it if it was a more proximal tear right off the bone. But when there's not enough tissue there, we can stretch it and we can pull it, but you're not going to have that same result. So I had to be very honest with him. And ultimately, he agreed, and he proceeded with the reconstruction, and he's doing very well. Thank God. But I guess my point is that just because it's something new doesn't mean it's better than the one that's proven to be effective. Maybe in the next 10 years, we'll find out that an ACL repair is better than the reconstruction, but we just don't have that data. And at some level, it's a bit of a risk then to proceed with the repair when you're at such a high level. If you're a recreational athlete, if you're even not athletic at all, but you're just feeling unstable and you don't want the process of the graft and implantation, then that is a good candidate actually for a repair at this stage. And I've done plenty of repairs for patients like that, and patients do all great. But if you're very athletic, and particularly at a high level, I would be guarded about proceeding with something that's not necessarily as proven as the gold standard. I'm Dr. Leon Popovitz. Thank you so much for joining me.